All right, I think we'll start the session. So welcome everyone today to the Health Terminology Standards virtual mini conference in incorporating the social determinants of health into digital health systems. While we wait for everyone to just join, feel free to use the chat to introduce yourself and to the group and where you're from and where you're calling in from today. Before we begin, I wanted to acknowledge with respect to the land of the Lekwungen peoples, known today as the Songhees and Esquimalt Nation, and the Wasatch people, all whose culture, the spirit of its people, and connection with the land in Salish Sea continue to this day. With the presentation based on the social determinants of health, it brings to light the importance of engaging in anti-colonial actions to address the historical and ongoing inequities experienced by Indigenous communities. The mini conference is part of the Health Terminology Standards lecture series, seminar series from the School of Health Information Science from the University of Victoria, and is being hosted by Canada Health Infoway and the Canadian Institute of Health Information. It is also a way to launch the new working group that I'll be co-facilitating with Dr. Annalyn Coughlin, which is being hosted through Canada Health Infoway, and we're going to be looking at social determinants of health. So if you want further information, I'll provide that at the end of the session. Today, you will be hearing from Julie Stratton, who is this senior researcher at the Canadian Institute of Health Information, and she's part of the Canadian Population Health Initiative. Then we'll have Andrew Pinto, who will be presenting on social determinants of health from the SPARK study in the Upstream Lab. And he is a clinical scientist at St. Michael's Hospital and founder of the Upstream Lab. And then we'll end with Sarah DeSilvi, who's the Director of Clinical Informatics and has been orchestrating the Gravity Project. And she is also from Northwestern Georgia Health Center and a clinical instructor at the University of Vermont. In case you're not able to attend all of these sessions, we will be recording them and be sending out the link after the sessions to let you know where you can find them. We'll be posting them both, I believe, at UVic and on the Infoway site. For answering questions, there's two chat windows. There's two windows at the bottom you'll see. So there's the chat where you can speak to everyone who's attending today. And then for questions, if you can use the Q&A section. We'll be answering questions at the end of the session and having about a 15-minute question period and then taking a 10-minute break so we can get up and stretch before we go to the next presentation. So I'd like to begin by welcoming Julie Stratton, who is our first speaker. Julie Stratton is a senior researcher with the Population and Indigenous Health Division at CIHI and has a Bachelor of Science in Environmental Health and a Master of Health Science in Community Health and Epidemiology from the University of Toronto. Julie has spent the majority of her career in the public health sector, working at the local and federal level. She has experience in analysis and reporting on population health data from a social determinants of health perspective, and is continuing this work with the Canadian Institute for Health Information. So thanks, welcome Julie, and I will turn it over to you.
Great. Thank you, Marcy. Good morning, everyone. As Marcy said, my name is Julie Stratton, and I am the senior researcher with Population and Indigenous Health Branch at CIHI. Really happy to be here today to speak to you about the social determinants of health and actually equity collection and reporting standards at CIHI. Before I start, I'd like to acknowledge that where I'm speaking today is on the traditional territories of the Wendat, the Anishinaabe Nation, the Haudenosaunee Confederacy, and the treaty lands of the territory of the Mississaugas of the Credit, and recognize that this land is now home to many of the diverse First Nations, Inuit, and Métis people. Next slide, please. Sorry. During my presentation today, I will provide an overview of the structural and social determinants of health, talk about the work CIHI has done it related to equity and future equity work. Next slide. I want to start this presentation by orienting you to just a couple of terms and definitions. This slide shows a visual of the various structural and social determinants of health. The left-hand side shows examples of structural determinants, which are defined as the root causes of health inequalities. Structural determinants are those things that affect whether resources for health are distributed equally in society. Some examples on the left-hand side include social policies like housing and the labor market, or public policies such as education and health. As you move toward the right-hand side of the slide, you get more into what are called the social determinants of health, which are defined as social and economic factors that can have an impact on health. And some examples of these include education, income, and occupation. This presentation will focus more on how CIHI is thinking about the social determinants of health in terms of how to define, measure, and analyze. Next slide. This visual from BCCDC shows the many different types of social determinants of health. These will be familiar to many of you. Includes things like income and education, gender, race and racism. And while these concepts are not new, they've really been brought to people's attention over the past year as it relates to the COVID-19 pandemic. Before I get further into the slide deck, I'm going to show a short video just to give an introduction to the determinants of health and measuring these inequalities.
In Canada, we take pride in our universal, publicly funded health system. As Canadian residents, we have free access to physician and hospital services no matter what part of the country we live in, where we've immigrated from, or where we work. However, access to healthcare is one of the many factors that determine health. Healthcare systems also need to consider things such as social supports, healthy child development, physical environments, income, and education. These factors are called determinants of health and play an important role in contributing to healthy populations. Meet Eddie. He lives in a low-income neighborhood where he is excited to start grade 1 so he can ride the bus to school. He's just been hospitalized with asthma for the 3rd time this year. Analysis by the Canadian Institute for Health Information, also known as CIHI, shows that hospital admission rates for asthma have on average dropped by 50% over the past decade. This is a good thing. But what about Eddie? What if we told you that some children are admitted to hospital more often than others? Meet Sandra. She lives in a high-income neighborhood where she walks to school with her dad and will be starting grade 2. She also has asthma, but hasn't been hospitalized since she was diagnosed as an infant. According to CIHI analysis, asthma hospitalizations are 1.5 times more common among children living in low-income neighborhoods like Eddie, compared to children living in high-income neighborhoods like Sandra. A difference in health across population groups, such as the low-income and high-income neighborhoods, is called a health inequality. Sometimes health inequalities are unavoidable. For instance, when a health difference can be attributed to a biological factor, like your DNA. Other times, health inequalities are unfair and avoidable. This type of inequality is considered an inequity, like differences by income level. By eliminating unfair and avoidable differences in healthcare access, for example, we can achieve a more equitable health system. Measuring and understanding health inequalities is a critical first step towards informing action to improve health equity. This is because averages do not tell the full story. For example, earlier we told you that the average asthma hospitalization rate has decreased in the last decade. However, looking at the overall average does not show how many more kids are being hospitalized from Eddie's neighborhood compared to Sandra's. Healthcare systems can use information on health inequalities as they seek to improve access to quality care and health outcomes. Ultimately, health systems strive to ensure that these improvements are shared across the entire population. So how exactly do we measure inequalities? We can do this by measuring and reporting on indicators by population groups, such as Canadians living in richer and poorer neighborhoods, like Eddie and Sandra. We call this equity stratification. At CIHI, we stratify indicators in different ways, including by age and sex, and increasingly by neighborhood-level income and geography. In collaboration with experts across the country, CIHI has developed standard definitions for equity stratifiers to support analysts with measuring health inequalities. These definitions are featured in a toolkit, which is designed to help you plan your analysis, analyze your data, and report your findings. Using this CIHI toolkit, you can identify health differences and monitor progress towards closing the gap between subpopulations. Equipped with information on health inequalities, you can continue to improve health and healthcare service delivery for all Canadians. For more information and training, visit cihi.ca.
Next slide, please. So that video was a great overview of social determinants in general, started to get into a measurement and some definitions. So I'm going to go into a little bit more detail now in the rest of this presentation around what you just saw in that video. First, a couple of definitions. The first is health equity, which was mentioned. This is defined as the absence of unjust, avoidable differences in healthcare access, quality, or outcomes. It is a judgment, meaning that you make a determination that there is equity or inequity. Now, I'm sure that many of you have seen this image that provides a great visual of the difference between equality and equity. The people on the left all have the same size box, which in theory means they should all be able to get their apple because they're all getting equal treatment. However, the people are all different sizes and some just can't reach that apple. And because of this, you might say there's inequity at this apple farm. So in order to change this, different size boxes have been provided to the people depending on their need. And this ensures that everyone can reach an apple, which brings equity. Next slide. The other two terms I want to mention are health inequality and equity stratifier. Health inequality is defined as the measured difference between subpopulations. You can assess this difference by cross-tabulating your health data using equity stratifiers or determinants. An equity stratifier is defined as those characteristics, usually the social determinants of health, such as age, sex, and income, that you can use in an analysis of your data to determine inequalities between groups. Next slide. So in the next few slides, I'm going to provide an overview of what CIHI is doing as it relates to this equity work. And you will see the term equity used a lot in CIHI products. This is because CIHI's goal is to advance health equity. Next slide. CIHI has been publishing reports with inequality measurements in it for many years. And in 2016, hosted a formal stakeholder dialogue on data and measurement in order to further advance health equity work. Participants in this dialogue represented ministries of health, quality councils, health regions, academia, practitioners, and national organizations and the federal government. They all shared their perspectives on priority data needs to facilitate the measurement of equity in healthcare. While there were many stratifiers that were discussed, participants identified race, ethnicity, and Aboriginal identity alongside age, sex, gender, education, income, and geographic location as priority equity stratifiers for development. Those are the ones highlighted in bold white. This group of dialogue participants called on CIHI to establish working groups to refine and review stratifier definitions, as well as to discuss how to access and/or collect stratifier data. Next slide. As a result of this dialogue, in 2018, CIHI released In Pursuit of Health Equity, defining stratifiers for measuring health inequality. In conjunction with Statistics Canada and external stakeholders, CIHI developed standards for how to measure age, sex, which is defined as sex assigned at birth, gender, defined as lived gender, income, education, and geographic location, which was defined as urban and rural remote. Next slide. This slide just gives an overview of each of the developed stratifiers, the associated construct it is intended to measure, and how they are measured. For example, the stratifier sex is defined in this document as sex assigned at birth, with male and female as the valid options. Next steps in this area of work around the standards are to continue to add new stratifiers to this repository and to explore opportunities to include stratifiers within CIHI databases. For example, are there ways that we can conduct data linkage in order to get them into our holdings? Following that report in 2020, CIHI released draft standards for race-based and Indigenous identity. Next slide. In this document, race is defined differently than ethnicity, where race is a social construct used to categorize people based on perceived physical differences, such as skin color or facial features. Now, there is no biological basis for these distinctions. However, disaggregation of health indicators by race can be used to identify, monitor, and address inequalities that might be the result of bias and racism. Sorry, can you move to the next slide? Ethnicity is a multidimensional concept referring to cultural group membership. It may be connected to language, religious affiliation, or nationality, among other characteristics. Ethnicity data can also be useful for tailoring culturally appropriate health services and understanding diversity. Race and ethnicity are frequently misunderstood and are often conflated in health data collection standards, surveys, and discourse. And a better understanding of these terms will allow for improved data collection on population subgroups. Next slide. This is CIHI's proposed race-based standard adapted from the Ontario Anti-Racism Directorate using a preamble from the Upstream Lab Spark study for primary care. This is a self-reported, self-identified approach to measuring race, and respondents can select all categories that apply. CIHI has also included Indigenous identity as a group within the race-based question to reflect how Indigenous people may be racialized by society. This standard was used by many public health organizations across the country as part of the COVID-19 response. Next slide. Indigenous identity data are often collected alongside racial and ethnic categories during data collection. Although Indigenous populations experience racism and have their own unique cultures, they may not identify as racial or ethnic groups. So we've included in the proposed standards a separate question for Indigenous identity that is distinctions-based and separates out First Nations, Inuit, and Métis groups, allowing for additional self-identification. There is a need to respect Indigenous self-determination and data governance in this space to minimize any risks of harm. We've learned through our work to date that Indigenous identity data and measurement should be determined and supported by Indigenous communities. We are in the process now of engaging with Indigenous organizations, communities, and researchers for feedback on this approach. And we're approaching this engagement in alignment with CIHI's Indigenous health strategy and with the collaboration of CIHI's Indigenous health team. CIHI also encourages organizations implementing data collection to engage and collaborate with Indigenous communities in their jurisdictions to find out how they prefer to be identified. Next steps in this area are to publish a What We Heard report based on our stakeholder engagement, followed by finalized standards in early 2022. Next slide. While not in scope for this year, considerations for the expansion of stratifiers could include the following: housing, disability, language for receiving care, health insurance, immigrant status, and sexual orientation. And I just wanted to flag that the process that was used to identify these concepts within the Pan-Canadian dialogue consisted of a variety of different approaches: in-person consensus building exercises, reviewing survey results of potential stratifiers, round-robin exercises, and ranking and then selection. Next slide. I also wanted to add that in determining these stratifiers, we used the following criteria: strength of association, strength of evidence, meaning that the stratifier is associated with access, quality, and/or outcomes of healthcare; accountability, meaning that inequality can be addressed through a policy or program intervention at the clinical or healthcare system level; accessibility and use, meaning that a definition exists that is standard, valid, and reliable, and has been used to measure inequality in healthcare; acceptability, meaning that the stratifier information would be willingly provided by Canadians without concerns over privacy and/or data ownership; and relevance, meaning the stratifier reflects a priority population for improving access, quality, and outcomes of healthcare. Next slide. Following the Equity Stratifier report, a toolkit on measuring health inequalities was created that helps users to plan their analysis, provides guidance for analysis of data, and how to report findings with additional links for other resources. Next slide. When planning your analysis, it is recommended that you identify your stratifiers, determine how you want to disaggregate, and then obtain your data, which can be used to create your an analytical plan. Within this slide are resources that are part of the Inequalities Toolkit, which can help with planning your approach. Next slide. Likewise, for the analysis phase, there is guidance and resources for conducting your stratified analysis and identifying inequalities using various summary measures. Next slide. So a little bit about inequality measures here. There are many different types, though there are those that measure absolute inequalities and ones that measure relative inequalities. And there are also distinctions between simple and complex measures. Next slide. For ease of understanding and reporting, it is best to consider a combination of both simple and complex, as well as absolute, which is difference-based, and relative, ratio-based measures. CIHI has selected the measures in red as ones that are more easily understood by a wider audience of users and ones that provide a comprehensive description of health inequality that reduces reporting bias. Next slide. And now I'm just going to go over a few examples here about how they can be used and what the interpretation would be. So next slide. The rate ratio is defined here as a simple measure of the relative inequality between subgroups that is calculated by dividing the rate of the lowest income quintile by the highest income quintile in this example. For example, dividing income quintile Q1 by Q5 gives you a number of 2.4. This means that the rate of whatever it is you're measuring is 2.4 times higher in the lowest quintile compared to the highest income quintile. Next slide. The rate, next slide. The rate difference is a simple measure of the absolute inequality between subgroups that is calculated by subtracting the rate in the lowest versus the highest income quintile. And in this example, we get a number of 93, which simply means that there's a difference in the rate of whatever it is you're measuring between the lowest and highest income quintile of 93 per 100,000. Next slide. The potential rate reduction is a complex measure of relative inequality that captures the potential reduction in a health indicator that would occur in the scenario, hypothetical scenario, that each population subgroup experiences the same low rate as the subgroup with the most desirable rate. It's also commonly known as population attributable fraction or population attributable risk. And then the interpretation here with our result is that approximately 30% of outcome X could have been avoided if all income quintiles had the same rate as that in the highest income quintile. And finally, next slide, the last one that I will talk to you about is the population impact number, which is defined as a complex measure and it's absolute in terms of inequality. And it looks at the potential reduction in the number of cases, not the percent, but the number of cases or events for a health indicator in the same hypothetical scenario where every subgroup that you're looking at experiences the same rate as the one with the most desirable. So it captures the gradient of inequality across multiple categories. The interpretation here is that there could be approximately 9,000 fewer of outcome X if everyone in all income quintiles had the same rate as Q5. Next slide. Finally, the Health Inequalities Toolkit also provides guidance for interpreting and presenting your findings along with additional resources. Next slide. A couple of the other features and resources I'm going to speak to you about, which I think are helpful. This particular intervention scan guide is helpful to inform the process from analysis to action. So once you've completed that analysis and determined your inequalities, what do you do next? The guide was developed to help you with identifying potential strategies, policies, or programs that can help reduce the health inequality that you have identified. Next slide. This is another resource that is helpful called the Area Level Equity Stratifiers using the PCCF and PCCF Plus. Speaks to some key considerations when measuring specifically income and geography related inequalities when you're using an area-based analysis approach. So this is a great resource if you're planning to look at those two stratifiers. You can use this approach when you don't have individual data about a stratifier, but that you can calculate inequalities by linking your data to higher levels of geography for an area-based approach. Next slide. The SAS Macros and Methodology Notes Toolkit is a document that provides methodological guidance for calculating indicator rates and calculating summary measures of inequalities, and also includes SAS code to go along with that. Next slide. These documents provide additional information about definitions related to equity and other resources, equity-related sources. Next slide. I just want to flag here too that the Health Inequalities Interactive tool provides inequality measures for selected indicators that use sex and income quintile. While this is available online with data, I do want to note that while it hasn't been updated in some time, it does provide examples of analysis and how you can display inequalities data to a wider audience. Next slide. Finally, here are just a few examples of CIHI reports that have included inequality analyses. These and other reports are listed in CIHI's, listed on CIHI's Health Inequalities webpage. Next slide. What's next for CIHI? One piece of work includes the expansion of selected equity stratifiers within CIHI databases. For example, the addition of adding area-based income into some selected data files to help with analysis. Another activity includes the expansion of analysis and reporting of health inequalities for CIHI indicators. So, you know, if we're adding in some of these area-based variables, being able to report some of that more broadly. And finally, continued stakeholder engagement related to identification and development of future stratifiers. And that brings us to the end of my presentation. I want to thank you for attending today, and I'm happy to respond to any questions.
Wonderful. Thank you so much, Julie. Lots of information there and great resources as well. So thanks for all of that information. There's a couple of questions that came up in the chat window. And Waldo, I believe it's from Infoway and has been working on looking at inequities as well. And so one of the questions, I'll just read them out loud. So there are white people who identify as Indigenous. Similarly, there are Latinos that are identified as Caucasian. Now, between race and ethnicity, which do you think has the greater impact on health inequalities is the first part of the question. And then a couple of other points that Waldo raises is race and ethnicity are considered as social determinants of health. Therefore, they can potentially generate health inequalities. And what do you think is the role of the healthcare system in fixing structural and systemic racism? Huge questions.
They are huge, but they're great questions. So I'm just trying to see them.
Yeah, and then
they're in the chat, or they are in the Q&A?
They're in the Q&A. And then the third part to that was you've shown different measures, indicators related to every stratifier. Is there a measure, indicator, or index completing all of these measures in order to measure intersectionality? And actually, that's a great question because that's
yeah. Okay, maybe we can just start. I can't see
them.
No.
The Q&A part. Okay.
I can't see the Q&A. So if you can just
maybe do you want to? So maybe the first part was so between race and ethnicity, which do you think has a greater impact on health inequalities?
Yeah. Now I don't think I can say which one has greater impact. I think they both have value in this space. So I think, like earlier in my slide deck, it depends what you want to be measuring and what the intention is. So ethnicity may have the opportunity to give you insight into, depending it is what you're looking for. Race is a great measure for looking at the potential of systemic racism. So you should probably disaggregate if you can. It's not easy because those data are not routinely collected, but I would say they both have some value depending on what you're trying to achieve.
Yeah, great. And maybe, I guess, a follow-up kind of to this is what I've been thinking about too, is and ties into the intersectionality question that Waldo raised, was with COVID, what we've been seeing is the impact on race and ethnicity. And when you were presenting, I was struck by how age has really come to the forefront, particularly with our older adults and where they live. And then also with race and ethnicity, it's not just urban and rural environments, but where the people, the different neighborhoods within BC, it's become apparent. I'm sure the same is happening in Ontario, where we're seeing different impacts of COVID based on geographic location. So I was just curious if there's been thought around there, how to kind of shift from this thinking of urban and rural to a bit more intersectionality, I guess, around that.
Yeah, it's definitely a space that CIHI is interested in. We have some recommendations around looking at multiple stratifiers, but I completely agree with your comment about the conversation related to COVID. And some of the things to think about are looking at one particular measure is not going to tell you what else is going on behind it. So I know that many public health units were reporting on race as part of their COVID case pieces, but it doesn't tell you the story behind, because race is not the driver behind COVID. It's other things that are happening related to the social determinants of health. It might be the type of employment you have. It might be how you have to travel to work. There are lots of other things behind the term race. So it can help you identify something, but you still need to do more of that digging to understand what is really going on behind that. COVID doesn't pick people because of their race. COVID affects people because of other underlying determinants.
And that excellent point, because that's what I've been thinking around as well, is it's not someone's individual characteristics that impacts it. It's all the social structures and behind that is generating these inequities, right? So I want to encourage people to type in some question and answers, and I see a few more coming in. So there's a question from, and my apologies if I mispronounced your name, Amadou, regarding race or ethnicities, race or ethnicity stratifier, and why all Black groups are combined together to one group as Black while others are separated out. So why there was just, I don't know if you know the decision behind that as why.
I don't know the decision behind that. I'm sorry, I am newer to CIHI, so I was not around for the initial piece. I will flag, though, that there is continued engagement to determine, like, is this the right categorization? Are there recommendations for other ways to split things out? So they are draft. They're not final standards, and so I think that's the important piece. And we CIHI recognized the need to make some draft standards out, which was really helpful for the COVID response for public health. They at least had something that they could collect with a common standard, but also recognizing that there's still lots of dialogue that needs to happen to determine how should we really be separating that out. I think the other piece that's come up when you look at the Indigenous identity one as well is that we're hearing lots of feedback to say, yeah, those are three categories: First Nation, Métis, and Inuit. However, there might be areas that want to collect it completely differently, and that's okay. And that's part of the dialogue that needs to happen to make it meaningful for people.
Yeah, great, thank you. The other question that has come up around these different index. So there's the around vulnerability or deprivation index, and is CIHI working on a similar approach? I think it gets to that intersectionality piece as well.
Yeah,
so
we are not currently working on, we're aware of all the different indices. I think some of the caveats about the indices are, again, you might have a grouping that identifies a certain outcome, but what is the driver behind it? If one of your components includes low income and single parent and something else, and you're finding an association, how do you disaggregate that in order to figure out what action you need to take? If the issue is associated mostly with single parents, that might not have anything to do with one of the other factors. So I think, again, like when you're doing these kind of analyses, you have to look at it in many different ways, but you also need to be able to disaggregate. So those indices are great in some instances, but you may also need to peel that back to determine what is really driving that outcome that you're seeing.
Thanks. And there's some questions around the stakeholder engagement. So it'd be helpful to know, for those of us who are developing surveys, how you're also following the OCAP principles. So OCAP is, I believe it from the First Nation perspective, and how to actually share data back with the community and engage them.
Right, and can you just repeat?
So what the question? How you're actually thinking around those OCAP principles and bringing that into stakeholder engagement.
Yeah, so CIHI is taking the approach of no release of Indigenous data without that relationship with Indigenous communities, definitely. So, and we are kind of at the early days of this journey. We are meeting with lots of stakeholders to have these discussions about data, but I think the one premise that we need to put out there is that we don't release anything related to Indigenous groups without those conversations. And I know that has come up with other groups as well who have similar thoughts, and so that could be another area that we hear from some of these engagement pieces.
Great, thanks so much. So I'm going to keep going through all the questions today. So I just going to, there's another question around impact on COVID measures, and where people, based on where they're working or staying from home, and the closing of gyms, and how this may be increasing the gap around inequality, and the example of access to mental health services and that. So are there other measures, I guess, that that COVID has really revealed that CIHI is looking at around some of these other aspects?
Yeah, CIHI has done has quite a few pieces of work. If you do go onto the CIHI webpage, there are reports that have come out looking at some of these topics. So impact of COVID on falls, impact of COVID on hospitalizations and ED visits. I believe there's a substance use one in there too. I apologize if I haven't quite got that correct, but there are a number of reports that have been released where CIHI is trying to look at what are some of those impacts on population, like reduced surgeries and that sort of thing. So it's definitely high up on the radar to monitor and see what some of these impacts were on at least for health services. And there are lots. Public health is looking at a lot of other potential pieces as well. So it's an area of interest that I think a variety of different groups will be engaging to measure after this pandemic is done. Like, what were some of those other impacts from a social end, health behaviors, and even health outcomes? Yeah.
Great. Yeah, and I'm all and my background's within seniors health, so I'm really curious of what we can do to shift some of the impacts around that as well. So that's great. The other question is how to address the issue of forming and collecting identifiers when power dynamics, such as political and legal, also align with colonial efforts to control First Nations communities. So I guess some of aspects around colonialism I've read around being a social determinant of health itself. So how do you address some of those issues of collecting, I guess, Indigenous identifiers when there might be existing power dynamics around these colonial structures?
Mm-hmm. Great question as well. And I think CIHI has an ethics framework that will be used to start testing against some of these new collection pieces, to ask some of those questions, to make sure that are we doing more harm than good by asking, are we engaging with including the right individuals. So I think for any kinds of new data collection, using that kind of ethical framework thinking is really important, and it's great that CIHI is well on its way to start implementing that.
Yeah. So, and this is another question, linked to that was, are there specific Indigenous stakeholders being engaged with, that you're engaging with, and can you share who you are engaging with, or is it, I guess, across provinces and territories, or I don't know if you can share that information. So
yeah, unfortunately, I'm sorry, I don't know the answer to that question in terms of the details, but I can certainly connect you with the name of the manager in our Indigenous for our Indigenous health team, who could certainly provide more details on some of those engagements and relationships that CIHI has with Indigenous.
All right, great. And I think, yeah, so I believe your contact information, is it, I guess that's a question, how best to reach you, or is it, yeah, I guess how's the best way to follow up on that piece?
If you would, yeah, I'm happy to share with you via email the name of that person, however you want to share it, but yeah.
Perfect. And then there was a question earlier in the chat window that I just remembered was, I know that you showed the video, and it's available, I think, on YouTube and CIHI's site, right? And there was a second video that you were wanting to show, but because of limited time, we weren't able to. And what was that one? I know there was a link to the one that you'd shown, but it's slightly different. So
yeah, it gets more into the inequality measures. So if you want to understand better about, the rate difference and the rate ratio and what does it mean and how do I need to think about it, that video gets more into detail on the actual those measures, and working through a bit of an exercise. So I thought, yeah, there wasn't enough time to show that, but certainly if you are interested more in that analytical end, that would be a great video to watch.
Perfect. And I think they're both on YouTube, but that's where I found them. So yeah.
They're also available on the CIHI website. If you just Google health inequalities or health equity CIHI, all those resources and videos are available.
Excellent. That's great. How do you, so I'll jump back to the questions in the Q&A. How do you see the role of CIHI in implementing the use of equity stratifiers across the country? Example where they're almost not collected for COVID-19.
Yeah, no, and it's a great question. I mean, I think the thing to think about is a lot of our health systems weren't designed with these stratifiers in mind, right? They were built many years ago. It's very expensive, and we might think it's easy to make a change into a system like that, but it's not. So, so when we don't have that kind of information embedded within a database, CIHI is looking at different ways. Are there different ways that we can try to bring that stratifier into the database? So the example that I gave in the slide deck around those area-based measures, income has been added into some of our databases as an area-based measure to kind of help get around some of those problems where you simply cannot collect some of them. Education is another one that we are exploring, and then we will need to start thinking about things like how do you get gender in or clarify that when it's different across systems, and then how do you get in kind of things like race or ethnicity, Indigenous identity. So there's still so much work to be done, but small headway in getting a few of these stratifiers into the database, given that you're working with very large system and very different systems across the provinces and territories.
Yeah, just with the working group and thinking around developing standards, I've been doing a scan, and that's the thing. Where do you start? Because there's so many that you could look at, so yeah, I think the ones that you started with are some key ones, and it kind of falls up to a question around: have you also looked at immigration status? And I know this is one of the questions in the tool that has been developed through the SPARK study, is around immigration status. I can't remember the exact question, but has CIHI looked at that as well? So
no, we haven't looked at it yet, but it was when CIHI did the Pan-Canadian dialogue, there was like the first block of stratifiers that were age, sex, gender, income, education, geography was the first block. So we worked on developing standards for those. Then there was like a second grouping. Immigrant status was included within that. And so one of the things that we will be doing this year is a bit of an assessment to determine which one of those should we start working on next. So, you know, of course, that includes what did we hear from stakeholders and what's going to be most important. So,
yeah,
but it was one of the ones that was on the list.
Perfect. All right. So I have two more questions, and then I think we'll wrap up. But before I do, actually, I'll ask the two questions, and then I think Francis might have a question as well. So I'll see if he wants to ask it at the end. But one of them, the one question is, why was one of the criterion for selecting health equity variables that the system could access it correct? Most structural determinants are outside the healthcare system, which makes them a wicked problem. Why did CIHI decide to focus on income and not occupation, and how does the healthcare system correct for income inequality?
Yeah, that's
yeah. You have 30 seconds.
It's the million dollar question.
Yeah.
No, I know, and I think it's trying to find. It's finding those opportunities for your organization. So the example that I think is easiest to think about is if you know that if many of your clients, let's say, are in lower income, you can't maybe necessarily correct the problem of structural, wherever that is. But you could potentially connect them to resources. Have you filed your taxes? Did you know you can get these additional rebates? So just knowing that is existing in someone's life, you could maybe connect them to other resources that are out there. And I know that's kind of a simplistic view to it, but it's because that piece is really big, and I think that's where people get stuck. So it's trying to figure out, what can I do in my organization if I had that information to help inform a change for that person.
Yeah, that's what I've also found is there's the poverty tool, which you can ask people, are you having difficulties making ends meet? And then if people respond yes, you can link them to different services, right? And instead of thinking that you have to change their income, you can provide additional supports around, right? Yeah. And then what knowledge translation initiatives does CIHI have in place to action the data coming in? So the data that you're collecting in that,
Yeah, so CIHI routinely reports on a variety of different indicators across many of the different databases. Those are available in something called Your Health System. So that's accessible online. There are different degrees of access, but certainly there are public facing pieces. And then there are other data that get published in reports and whatnot that would be available for public consumption. So those are the two that come to mind. I know that we're coming close to time here, but yeah.
They're great. And I think all the resources that you linked in your presentation provide some excellent resources too. And then I'll also say CIHI has been great at promoting this event too. So there's all the hidden networks, I think, that we often through social media and that. So Francis, do you want to ask your question, or has it been answered?
There are actually a couple of questions from the participants in the chat box.
Okay.
I'll leave it to you to decide because the time is running out.
Yeah, time is up. Just going to see if in the chat box. There are quite a few. Julie, would it work if I forward these questions on to you, and then we can send a response out to the group about some questions around these questions?
Yeah, I like that idea.
Yeah.
That would be great.
Yeah,
And and thank you everybody for all of your questions. It's great to have these kind of conversations, and it'll be, if there's things in here that we can take away, that'll be great too. So that would be helpful.
Yeah.
Thank you.
Yeah, and what I also want to say is, yeah, it's just the start of, I guess, of what we're discussing, and that's really part of this is to launch the social determinants of health working group. So these are excellent questions for me to think about too, in thinking about how to design the working group. And yeah, Julie, I just really want to thank you so much for all the time you spent with us today, and the questions, because like one of the questions came up. These are wicked problems we're dealing with, and so how do we really address these? And so I really appreciate your time and all your insights around this. So thank you.
Thank you, and looking forward to the next speakers.
Yeah, great. So we're going to take a 7-minute break and start up right at 10 a.m. Pacific time, and do my math, 1 o'clock in the afternoon for some of you, and then 4, I guess, on 2 o'clock for people on the other side of the water. So great. Talk soon. Thank you. Everyone. So I'll give everyone just a minute to jump back in before we get started. All right, so I'm going to get started again. And so just welcome for those of you who maybe weren't able to attend the previous presentation. Today we have Julie Stratton, who just presented. And next we have Dr. Andrew Pinto. Hi, Andrew, great to see you again. And so I'm just going to do a quick introduction on Andrew. And Mena, I think, is going to give you power to share your slides. So that'd be great. So yeah, Dr. Andrew Pinto is the founder and director of the Upstream Lab. And the Upstream Lab is a research group focused on integrating health and social care, population health management, and using data to enable proactive care. He is a public health and preventative medicine specialist and family physician at St. Michael's Hospital and associate professor at the University of Toronto. He is the associate director for clinical research at the University of Toronto, practice-based research network, Utopian, and the lead for artificial intelligence in a new initiative at the Department of Family and Community Medicine on how new technologies will change healthcare. And so just a reminder, if you can see the question and answer, if you can type your questions in there, and I will pay attention a bit more to the chat window as well. So when we ask questions in the follow-up section with Andrew, I'll check both sections. So but ideally, if you do have the Q&A, if you could type your questions there. Thanks so much, Andrew, and I'll turn it over to you.
Thanks so much, Marcy. And I just want to say thank you to the organizers for inviting me to speak today. It's a real privilege. And I should note that, although I'll be presenting, it's really on behalf of a huge team of people at the Upstream Lab and many of our collaborators, patient partners, and colleagues who are part of the various pieces of work that I'm going to share today. I'm just going to begin with acknowledging the land on which I'm meeting and based in, which is in Toronto. This is the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. And I'm very grateful for the opportunity to live and work on this land. And also, as part of acknowledging the land, as part of that, I try to highlight work that's relevant to the topic that I'm going to be speaking about, in this case, around data. And I want to just really highlight this fantastic paper and report that just came out just a few weeks ago. Includes an international team of folks, but including Robin Rowe, who's a stellar PhD candidate at Laurentian. And I really encourage you to take a look at it. It really speaks to Indigenous people's data during COVID and has these 5 recommendations around the collection of data and also its use, and really the importance of principles like OCAP around its use. So this is the Upstream Lab. We're a diverse team of folks who I'm just one of many people. We have a great group of graduate students, staff, and many others involved with our work. We divide our work into these 3 buckets. So work that we've been doing over the last 5 years since we've started around integrating health and social care and taking action on social determinants, population health management, and how we can do a better job in this area. And also, how can we use data and other pieces of evidence to engage in more proactive care as well. We do work, and I'll talk to some of the things we're doing around addressing the social needs of individuals, of patients, and of communities. Work on data, which we'll be talking about quite a bit today, as well as part of building a more proactive system is also engaging in education as well. And then also moving us to shift health organizations from kind of an individual focus to thinking about the population they serve. And I think in Canada, we're actually well along in this process. But we're in the early days of thinking about things like community accountability, and then also even more upstream ideas of how the work that we're doing to address and improve health is also tied to things like democratic engagement, policy interventions, and our social infrastructure as well. This is one framework that may be helpful to kind of make this more concrete. We published this in Canadian Family Physician a few years ago around how can health organizations engage in tackling the social determinants of health. And you can see it starts from data. And at the very top is this idea of robust and routinely collected socio-demographic data from individuals. This can be combined with the health data that our systems generate through our day-to-day work. It can be combined with health service data where we look and see how patients are using the health system in other areas like the hospital or social care or home care. And then also data on the community in which people are living and working and really their lives are embedded. And so what can this data do? So, and this will be a theme you hear me repeat, it's really about multiple levels. Data can be used at the individual care. It can change the care that I as a physician or as a health provider provide to people. It can lead to changes in how we manage my own practice or small community of patients. It can help me with identifying hotspots or where are we missing people in a consistent way. And where also, and we'll come back to this in a bit, where are we seeing evidence of systemic racism? We can also use data to drive change at the organizational level, changing business practices, how we offer our services. It can also then flow up into system evolution and changing who we build relations with, and then also upstream to advocacy, to actually advocating for policy change, which is really ultimately what shapes social factors. So to focus in on socio-demographic data, this work has really been going on for at least 10 years that I've been involved with it. And one of the starting points is this report, which was from an initiative called the Tri-Hospital plus Toronto Public Health Equity Project. It came about when people in different hospitals in Toronto started to come together and say, what we would really benefit from is a common set of questions that we administer to our patients to understand who we're serving and also to identify differences in outcomes. And I really want to point to the leadership of the people around the table at that time back in 2010, and particularly someone who's a really incredible person in the space, Camille Orridge, who is the CEO of the Toronto Central Local Health Integration Network, or LIN, at the time. And she, and I keep thinking about her words in this about data being important for accountability. Data alone is not going to create change, but it is one piece of looking at accountability and holding institutions to account for how they treat individuals differently. We were part of this pilot, and I was involved with this as one of the PIs. And we started at St. Michael's Hospital, which is the hospital which I practice as a family physician, started to collect this information within our family health practice, which is now grown to be a family health team that serves about 50,000 patients in the downtown east part of Toronto. So we learned a lot through this. I think one of the key findings was that patients, when asked these questions in the context of their care, and particularly within primary care, were not opposed to answering these questions. They actually understood that if the data was being used to help identify who needed what service, they were open to that. So we published some work on this, and then we got some funding from the Toronto Central LIN to study in more depth after a few years had passed. And we published a number of papers around patient views of collecting this data, and also really how good were the questions, how accurate were they. We learned a lot, and we then actually proposed some changes to the questions. And I think actually in what Julie presented, you see some of that reflected in what CIHI is produced, and over the last several years, it's really influenced our work, and I think our work has influenced their work as well. But certain things have changed. And I'm going to now go over kind of the questions as they've been updated. And we then went on to actually test this updated form of questions in 5 primary care clinics. And we learned a lot about them and about the implementation. We've made some further modifications, and now we're going to be testing the psychometric properties and validating these questions that I'm going to share. Just before I get into it, just want to keep this in mind. One of the things we heard from patients when we interviewed them, and I think this has been consistent over many years, is really when we ask patients, they very much feel that this data should be used to influence their care, should be used to intervene at the point of care. It should influence the type and quality of care that they receive. So that's been a central thing we've brought to these questions. At a second level, it can be used at an organizational level to help design better services, to adapt services, to deal with issues at an organizational level, and also engage in quality improvement. And then kind of at a third level, this data can be used for health system planning, to identify systemic inequity, to make decisions about funding, and also it can be used for research, but it has to really start with the patient at the center. So we received a large grant from Canadian Institutes for Health Research to carry out something called the SPARK study. It is in collaboration with many organizations, and we've received in-kind and financial support from other organizations, and it involves colleagues in Saskatchewan, Manitoba, Ontario, Nova Scotia, and Newfoundland. And we have wonderful folks advising this work, including from Canadian Institutes for Health Information and other groups as well. The objectives of this work are to develop and validate a standard tool for socio-demographic and social need data collection, evaluate the implementation, and then kind of somewhat separately now is a randomized controlled trial around addressing social needs. So getting into some of the questions, and I really would be interested in what people think. Again, you have to see these are questions that would be used in the context of clinical care. So they would be asked of people routinely when they come into clinics and are registered. So there is an aspect of these questions that you may see they don't have the same language or kind of cadence as, say, a census question or a question on something like a research study. They're meant to be to achieve multiple goals, improving care for that patient, but also in aggregate being used at the organization and then at the system level. So interestingly, with the original Toronto Central LHIN questions, which asked people what language they would prefer to speak with their provider, almost everybody, even in a very diverse city like Toronto, chose English. So we're testing now this different question more about translation and would it be helpful. Immigration status has been fairly straightforward and fairly easy for people to understand, and this has not changed very much. One thing is, of course, it doesn't distinguish between people's legal status or identify people who may have been born in Canada, but then they quickly moved to another country and essentially grew up in another country. So there's some limitations to this, but in general, it's performed really well. One of the biggest areas of focus now, I think, across Canada is around race and ethnicity. And we moved to kind of informed by the work that CIHI has done and work that we've done. We've moved from a question that combined race, ethnicity, and geographic location to now this question. And it really is actually based on the Ontario Anti-Racism Directorate standard that they had proposed. And one of the, I think, key things is actually conveying to a person who's being asked this question that this is not about differences in genetics, but the fact that our race and how we're perceived has important consequences. So right now we're at the point of engaging in validation of this question and asking people their thoughts. So we'll look forward to seeing how that goes. Sorry. And I'll just a note here that really much more work is required on Indigenous perspectives on posing these questions in health settings. And that's definitely something that needs to happen. And I'll come back to this point about governance and sovereignty and community engagement as well. Another area that has evolved is around asking about disabilities. So it's evolved to this more specific set of questions about challenges that people may face and how it would impact actually the type of care that's provided. And it's evolved from a previous question that really brought together many different things from chronic diseases to stigmatizing conditions and functions. So it's changed, and we have published a paper that describes kind of our journey to this question. Another area, again, which I think there's been a really great interplay with CIHI has been around an evolution of the question on gender identity to this two-part question about sex assigned at birth and current gender identity as well, and that's evolved. Also, the question on sexual orientation has also evolved and changed as well. One of the other kind of important aspects is separating out sociodemographics from social needs. And the idea behind this is that although there's certainly overlap in these concepts of our sociodemographics and our social needs, the idea is with these questions that there is something that the health system could do to actually help patients or individuals with these areas. And this ties into work we've done at the Upstream Lab around helping people with these different areas. So one kind of key thing that comes up is the question on income. Instead of directly asking people about their income, which many organizations have found and our research has found, people are quite reluctant, and they also actually find it hard to report on their income over the past year. We've replaced it with this question about having difficulty making ends meet, which in a British Columbia study has been found to be valid in terms of identifying people above or below the poverty line. But we're now kind of conducting some further validation of this question as well, with the idea that if people do identify they have difficulty making ends meet, there are actions in primary care and in health settings that could be taken to help people with their financial security and income security, but also it allows you to dichotomize the population into those who are expected to be above or below the poverty line. And I will say throughout this, there certainly is going to be clustering of how people respond around these questions. So education, income, prescription drug costs, housing, and that condition, including stability and ability to pay rent, social isolation, which is a really important area right now, transportation, and utilities as well. One area that people may wonder why it's not there is around food security, and that's in part because there's actually already a set of validated questions around food security, a two-part question that exists already in that area. So I guess some key insights from what we've done so far, and this is certainly a journey that we're on, and I will be the first to say I have much to learn in this area, and we have much more work to do. But I do think that we can achieve consensus on questions across organizations and jurisdictions. And I think we are coming to a consensus around these that are, again, the idea of a set of questions that would not only work for patients and clinicians, but also if they're administered across the population, really help with that organizational and then the system level picture. The questions are really never perfect, and we can spend enormous amounts of time with it. We do need to think about how questions evolve, even in the the decade that I've been doing this work, language has changed around many of these areas. But we need to strike this balance. Implementation is perhaps the greatest challenge in this area. And I haven't spoken much to that, but essentially our work to date really finds that this is absolutely key. And really what we find is if leadership is supportive, staff are trained, and patients really understand why, and there's trust in the organization, particularly around privacy, generally patients will respond to these questions. Just a point about collection of data on race during COVID. So early in the pandemic, many people in the spring of 2020 were really noting how there was a differential impact of COVID on racialized communities, particularly work from the US, where they collect data routinely. And so early on, the Upstream Lab issued this report, and I think it's had some impact on Canadian thinking, along with many other voices that were also calling for this type of data to be collected. One of, I guess, our key things was it should be collected along with other social factors such as income or housing or occupation. We really tried to encourage that there be the same question across provinces so we could compare. It's really important that there's a preface for understanding and that staff are trained, but really key is transparency around the use and engagement of communities around this. And CIHI issued its report in May and subsequently discussion paper after that in July or so. And it's really informed, I think, people's thinking in this area. Just an example of how the data was used very early. So after hesitation and reluctance, the Ontario public health system did move to mandate the collection of data on race during COVID. And it was used very quickly by public health units in Ontario to demonstrate the disproportionate impact. This is just one example from Toronto. And there's really great examples from Manitoba as well of how this data has been used to inform the response as well. I would say that it's definitely a journey, and there's a long ways to go to where this data is collected and it directly informs what happens in a public health crisis. Just a really important framework, and maybe someone can put this in the chat as well, the website here. But this was something that I had the privilege of being involved with, which is called the Black Health Equity Working Group. There's a group of leaders in Ontario really who came together to talk about a vision of what does community data governance look like around this data. And COVID was really a big part of the impetus, but these have been thoughts that have been circulating for a long time. And so it's very much a framework, and a lot of feedback was received by a community and by other groups around this. But the idea of looking at engagement that is genuine, ongoing, and transparent, governance around the use and interpretation of the data, access, which is a really important area that communities actually have access to their data, and protection of it. And this is a really new concept in some ways in Canada, the idea that individuals' information, not only is there an individual responsibility around protecting it and using it in an appropriate way, but also that there is a responsibility to diverse communities as well. And there's a community accountability and responsibility as well. And so I'll just mention this in the context of something that we're rapidly all witnessing the evolution, which is really looking at the role of data and AI methods that process this data on health and healthcare. And this is just a collection of reports over the last year or two from Canadian health organizations. You know, there's this really, I think, optimistic view of the potential of AI applications that people have put out, but there's also these concerns really about AI and what the potential is. And many folks have actually brought up the dangers and concerns about these applications, particularly to reinforce bias and systemic racism if these are not considered beforehand. And just like there are many, many examples now, but this is just one that kind of was highlighted early on in 2016 by ProPublica of bias in an algorithm used around sentencing in the US. But this is something that has been very much identified within healthcare applications, and certainly this type of data that we're all talking about collecting could actually further this as a major problem. So what are some of our next steps in this area? So one is we are conducting a study of the psychometric properties and also collecting in-depth people's perspectives on the collection and use of this data in a number of provinces. We're also, with collaboration with CIHI and others, working to validate these questions against, for example, census questions. And I think after these two parts, really, we will have a very good tool that is fit for purpose in routine healthcare settings, and that's something that we can trust. Not to say it won't continue to evolve, but I think it will be a good point that we're at. And then we'll be engaging with a number of clinics around implementation in primary care and really aiming to look at how that can be done. And we recently were funded by CIHI to do some work around mitigating and identifying bias in machine learning as applies to population health. So you can see how these different streams of our work intersect, and we're trying to be both very reflective and mindful of some of the challenges, while at the same time working towards the idea of using data around accountability and improving equity. Just some points about these are kind of our top 10 so far of really key considerations or core principles around data collection in health settings. So the idea of committed leadership and staff is central. Ensuring Indigenous data governance and sovereignty over the data. Community engagement around the data, as I've talked about. Transparency. Taking action, and this is perhaps one of the key things, which is ensuring that it's not just data collection. We've already seen examples where where health organizations just collect the data, and it seems like almost like that's they feel they're doing something about the issue. There's a really big need around continuous data quality, which all of the epidemiologists and biostatisticians in the audience will know, but something that if we don't put it into this, it doesn't happen. There's a key area around staff training and also quality assurance around that training and making sure people are kept updated and engaged in the actual reason the data is being collected. Communicating to staffs, which could include even like how we have signs in clinics and the type of even signals that we send to people that we're interested in this out of a sense of trying to achieve equity. There needs to be a process if people feel they've been discriminated against, that's clear. And absolutely around other personal health information, key issues around data security and privacy as well. So I'll stop there. And, if you'd like to follow our work, really our newsletter, which comes out once a month, is a good way. And happy to take questions as well. Thank you.
Great, thanks so much, Andrew. I'm just going to take my video off here. There we go. Thanks so much for the principle, because that actually ties into a lot of what I've been thinking about with the working group, and particularly how to stop focusing on the measuring, but really how to address inequities, right? So I really think that gets to the heart of it. There was a question in the chat earlier around how to ask, there's two questions that actually I think tie into the principle. One around the principles was how to collect data if providers are hesitant to ask some of these questions. An example was given around gender. And so do you have any suggestions around that, I guess?
Yeah, that's a great question. I guess a few things. The work that we've done to date has really been where people are given the questions and that they're self-administered rather than a member of the healthcare team asking the questions directly. And this actually back in 2010-11, a review that was done of the literature at the time to inform the Toronto Public Health and Tri-Hospital project found that that would be preferable, as people having the chance to self-administer the questions. There are definitely, caveats to that, like in the context of, say, an inpatient environment where people may actually be unable to answer the questions because they're so unwell. But in general, we've been really thinking about where people self-administer the questions. But what this question is getting at too is, what about where the leadership or providers are not on board, or and that I think is a key issue. I think there's a baseline level of engagement and commitment and understanding of the terms. And the reality is in many health professional training right now, there's a fairly limited training on diverse areas like around gender identity and sexual orientation. And that needs to be part of the process too. There's a reason, a few years ago, a study in Ontario found that a large proportion of gay men were not out to their primary care provider about their sexuality. And so, like, thinking about that and keeping that in mind, it's really important to ask why that is, and therefore, is this appropriate to ask this of patients, and what needs to happen on both the provider side, but also the clinic side, to create spaces for people. That's what one of our current studies is asking people about. What do they feel about these questions? What would they need to see to set the stage for them? And also, what are the really important assurances around data security that would need to be put in place around it as well?
Great, thanks. Yeah, actually it ties into the work that we've been doing around the sex and gender working group and the planning project, and that really the need for cultural competency and and leadership, and then also the environment. So having signage around letting people know that it is a safe place to answer these questions, right? So yeah, it really reflects what we've found there as well. One of the questions I had actually that kind of ties into this is if someone, I think on the race and ethnicity questions, you can choose multiple options, but how do you, if someone chooses multiple options, how do you actually report that when you're looking at like the graphs that you showed? Mm-hmm.
Yeah, so that's a common question that comes up, and I think there's several different approach to it. It's actually one of the things we really hope to explore too, which is for individuals to identify as mixed race. What would they choose, and do they see themselves in these questions? And there's also the option of people selecting multiple options if they have if they identify as both or as well. In general, what I think we're looking at is, with the information on racial identity, is really broad patterns of systemic racism. And so there's often, with this information, we could use it, and what other institutions that have collected this data have used it for is actually looking at these broad trends, like the COVID example. And so, even though individuals may answer the question by selecting more than one options, in general, you would still see a pattern. I think, you know, a big question right now, I think in our study group around this area is really, should that sort of information only be analyzed at the large organization or kind of population level? Because again, like we say in the question, it's not about individual differences in genetics or things like that. It's about how people are treated differently by organizations and institutions, including the healthcare system. And so really, is it necessary to link it to individual records or report on it? It's really more about the big pattern that's being seen, and also to track changes as well. One of the rare examples in Canada where we've seen this information collected and reported publicly and actually lead to strategic planning. If, you know, I think they're not yet, you know, we can't say it's led to action because it's really just been launched as their planning, is actually the Center for Addiction and Mental Health in Toronto, which has really been one of the organizations that's been thinking about this for a long time. And, you know, to their credit, they publicly released examples where, for example, Black individuals were being treated much differently and in a much more negative way than others. And then it actually informed their anti-racism strategy that they released in February or so. So what I think we would want to move towards is where there is that transparency around the data, which is, I know, a big step for health organizations to take. And also really where it leads to action, there's actual measurement of that action, that it could be measured. For example, is the use of restraints actually changing for individuals who identify as Black? Is it going down? Is that an inequity that's actually changing over time?
Yeah, I've wondered the same too, is do we actually need to have that data at the individual level, right? Or is it better to have it at a population level? It kind of ties into Finney's question that was asked earlier, but around how this relates to ethnicity. Do you see an ancestral background? I've also wondered about the term of cultural background instead of race and ethnicity, and do you see a difference between those?
I think they are really different concepts. I think, and I'm aware colleagues at Statistics Canada have been thinking about this for a long time, and there's a lot of media around the census that many of us got, and really their thinking, and the fact that they've actually been allocated a large amount of funding to specifically look into this area. But I guess my perspective is these are very different areas of cultural background, ancestry, and really what this question about race is getting at is fairly narrowly focused on the experience of how people perceive our race and how that changes how we're treated by different institutions, whether it's healthcare, the justice system, education system, or how we're treated within a workplace as well. So I think we can't try to capture everything in one question. And this is really, and that's why I think our preamble tries to make this clear. This is about how people are treated differently. We've gone back and forth about, should we just specifically say this is about systemic racism? In the question we have held off, but we are going to hear from participants in this study about their thoughts about that. But I think to try to just narrowly focus on that is kind of a good starting point. And then I think, you know, some of the other areas about how, for example, our culture or background changes how we engage with the healthcare system, or how it influences our uptake of health promotion or medical recommendations, how it actually interfaces with our own cultural understandings of health. That's a huge area. I think this is just a starting point.
Yeah, great. One of the questions that came up, speaking about Statistics Canada, was, and I've noticed in your survey too, is for gender you have male and female, and same with sex. And so, have you shifted in thinking that it should be women and men? And
yeah,
I guess
I should say,
yeah.
I think that now actually we actually have updated that to
Okay.
to men and women.
Okay.
Exactly.
Yeah. And how do you, I guess, second part to that, how do you see a way to keep updating with the changing language with some of these, in some of these areas?
Yeah, I think that area, and particularly the question about gender identity and sexual orientation, are two of the questions where there has been, over the last decade or so, a lot of changes in how, in the terms that are used. I don't know if there's any simple solution other than, I think there is a starting point, and then similar to big instruments like the census or the Canadian Community Health Survey, these things have to evolve and be updated. I think what would be quite neat is if there was a kind of a continually replenished reference group and community that advised on the language, but also helped guide the use around this data. I think that could be really neat. And whether that's at a national level or is more of a provincial and territorial level is I think something to think about. But the changing language and terminology is also, I think, really tied to the use and telling the story of the data, and ensuring that it's really the community that is telling the story around this. Maybe I just want a really great question from Annalyn that came up too, is about, should the question not be about people's experience of, if the question is really about racism, should not be about what people perceive you as, rather than self-identification. And absolutely, this is something that I think we've talked a lot about over the last few years about this. We've landed on continuing with how people self-identify, or specifically like which category best fits you. But I agree. I think there is over many decades, going back to the civil rights movement in the 60s in the US, there's been that debate going on that, is it really about how you identify, or is it about how people perceive you? There's for this work we've landed on self-identify, in part because we think that it's also about people sharing kind of their identity with the health system and who they are and how they see themselves. And so there's an aspect when we've done interviews with patients previously, which has actually been very affirming. In the paper that we published on the collection of gender identity and sexual orientation data, which was in CMAJ a couple of years ago, we shared that kind of the positive aspect for patients of being able to self-identify and say, this is who I am. So that's what's led us. But I very much agree that that really that it's actually a lot about how people perceive us and then how we're treated. The other aspect of this is there is by looking at these questions individually, we really are missing the intersectionality of different aspects of our identity and our position and how we're treated in society. So I think there's a whole nother area of work around how do we actually interpret differences, and that it's, to take the example of COVID, it's not only, certainly not only about systemic racism as people have experienced and how it leads to who during this time has been able to work from home versus who hasn't, who is working in an essential job, job protections, paid sick days, all of these things that ultimately influence who gets COVID or not. But how that intersects also with gender and also intersects with immigration status and many other factors as well.
Great, thank you. There's a couple of questions on income, but one of the questions I also wanted to ask was just how you see, so you had mentioned, I didn't know about the food security part, so that's interesting to, are there other aspects that you would bring in, and how do you see this, I guess, as developing this as a value set for broader than the 4 provinces that you've been engaged with, I guess?
Yeah. So right now it's been these 5 provinces of Saskatchewan, Manitoba, Ontario, Nova Scotia, and Newfoundland. And really the reason for that has been because when we submitted this grant application, this project aligned really well with priorities that had been set in those provinces around wanting to engage in work that was tackling inequities and actually aligned around this area of data. But there's I think our findings certainly will be useful for others. I don't think that I think that what needs to happen in each jurisdiction is really the challenging and kind of, you know, crucial work around engagement around the data. I think that's where a lot of the work will have to be, as well as around and very closely related is around the implementation. So how it's like not enough to create the questions. That's just like the starting point. And I think again, the work that colleagues at CIHI have done and the work that many people have done has kind of moved that forward, and we're starting to see kind of a set of questions that we could live with, that is not perfect, as will continue to evolve, but it's really going to be about kind of the next step around this data. One of the questions that I just seeing, I want to just, I guess, touch on is around the point. Well, one, I think, simple question was around income and household size. And I think that's actually something that we've done with other work, is asking people about what is their financial status, and then also how many people are actually being supported by this income. Interestingly, that can vary a lot. There's a lot of complexity to that, because does it include people who are dependents but not in your household? Does it include things like remittances to family members abroad? So there's a lot of questions. Interestingly, a simple question like, do you have difficulty making ends meet, or are you having challenges, seems to capture quite a bit in it. And so there's a related question around that about, does it take into account where the respondent lives? And exactly, it's like, because of its kind of simple nature, it would actually adjust for costs of living in other areas. But this is where the validation study is coming in. So what we are going to be doing that to actually ask people this question and compare it to, for example, are they above or below the low income cutoff for their area, and then be able to answer that question.
Great. I'm just scrolling through to see if we There's one question around, have you had any specific measures around cultural safety and humility? And I don't think you have yet, but
No.
I haven't seen it yet, but yeah.
It's a great question. It's a whole another area around that. Again, I guess one of the things to say is that these questions right now, they achieve one small piece of the overall puzzle, and it's not really it's not going to be all-encompassing for everything. A few questions. I think people have also been using the chat as well. I think we covered that these questions we see as being self-reported and likely it could be at registration. It could be at a different point. And I should note that we're actually, although our work has been based within primary care, it's not, it's something that's starting to be taken up, and we're doing some work in inpatient settings as well with colleagues who are also interested in this work. Again, kind of keeping with that theme of seeing these questions being used for improving patient care, and then secondarily being used to identify inequities. But they technically could be used in other parts of the system, from inpatient to home care services, etc. There's a great question about asking these questions to children and youth. That is a fantastic question. Some of our early work that we did at the St. Mike's Family Health Team, where we had been asking these questions over about a 3.5-4 year period. The way it was implemented in that context was by offering it to everyone when they came to see their primary care provider. And staff had been trained to offer it to everyone, families with young kids, everyone. But what we did find is that systematically there was a responder bias, in that many young families did not have this information. When we did interviews with staff and did also observations in clinics, kind of not surprisingly, what's found is that if someone comes into their primary care provider and they have like a kid or 2 kids or 3 kids, their hands are full, and the staff are quite reluctant to add something more, like saying, here's a tablet, would you like to fill this out for each child? So it can, again, that issue of implementation being so central, and that it can be really, we can easily miss these questions. And then there is that question about, so for what age, so all of our work has been with adults, essentially, in terms of the in-depth interviews. I think a whole nother area of work is about posing these questions to adolescents who could answer some of them themselves. But that's not been an area that we've done work in as yet.
Oh, great. I know it's 6 minutes to, and so there's just a couple of comments more, I guess, in the Q&A. So one was that self-identification is so heavily influenced by how one is treated. That's why ethnic identity is a fluid construct. And then there was a comment more about our question around, is it biased to referring to African and Caribbean who are geographically different as Black, whereas there are many Black Asians who are categorized as Asian only. So I guess that also ties into the question I had about how do you separate that out. So yeah.
Yeah, again, it's something that I think we'll be learning a lot about as we do this next step of the research. The Ontario Anti-Racism Directorate did consult quite broadly as they developed their question. But I think, of course, these continue to evolve. And I think what we have seen is actually a larger and larger proportion of Canadians identify as mixed background. And so being able to capture that is helpful. Again, I think this is why I'm really happy with the question, that we preface it really with this point about race being socially constructed, and that it's nothing to do with genetic differences, and really about identifying how we're treated differently by organizations.
Yeah. Well, thank you, Andrew. Yeah, I'll end it there so that people have a quick little break before we jump to the next session. Just really appreciate all your time today. And I guess one question we've had, but I can follow up with you, is just if the slides can be shared. I don't know if that's possible, but we definitely will have the recordings available. So yeah, great.
Thanks so much for having me.
All right, thanks so much. Bye for now. Or we might stay on, thanks. So we're going to take a 5-minute break. If we can jump back on at 11:01 Pacific time and 2 Eastern and 4 on the Atlantic coast. Thanks. everyone. All right, we're back for our final presentation. I'm just going to wait 1 minute because I know that we ended a bit close to the hour. So, I guess if we could share Dr. Sarah De Silvy's slides. There we go. Ah, perfect. Excellent. Thanks, Sarah. All right, so I'm just going to introduce Sarah, and just for those of you who may have joined, if you have any questions, you can put them in the Q&A box, or if you're not able to see the Q&A box, feel free to put it in the chat box too, and I'll be checking there as well. So I wanted to welcome Dr. Sarah De Silvy, who's been working on the Gravity Project. And Sarah balances practice as a rural family nurse practitioner with advocacy for addressing the social determinants of health in clinical community practice. Her area focuses developing the terminology to capture the process of caring for patients' social needs. And over the last decade, she's collaborated with colleagues at Children's Health Watch, the Food Research and Action Center, and Siren on medical and social care integration and interoperability projects, such as an overview of food insecurity coding in healthcare settings, existing and emerging opportunities, and the compendium of medical terminology code for social risk factors. Sarah's been working on the Gravity Project for, I guess, the last couple of years now, and trying to get national consensus in the US on an initiative to develop terminology to address social needs. And she serves as the director of clinical informatics, helping to weave the practice of social care, community-based approaches, and the literature of social risk into healthcare terminology. So thank you, Sarah. I'll turn it over to you.
Thank you, Marcy. I think, can you all hear me? Wonderful. So it is my honor to be here today talking a little bit about what's happening in the US and some international work regarding building data and data standards to address social determinants of health. Just want to thank Dr. Pinto for his presentation prior. I met Dr. Pinto through our colleagues at UCSF Siren, so it's always nice to hear his perspective. So if Dr. Pinto gave the why, so this is some further discussion on how to do this and how to do this well, and how to make sure that what we're documenting and what we're sharing across clinical settings conveys the meaning that we intend to convey. So this is who I am. I am the Director of Clinical Informatics of the Gravity Project. As Marcy mentioned, I am principally a family nurse practitioner in rural primary care just across the border in Vermont. So if you hear noise around, it's because I'm taking time out of clinic to present to you today, as usually is with Gravity, like fitting it in around different things. So I do actually, before I go any further, I saw a mention during Dr. Pinto's conversation regarding links. I tried to drop into the all chat many of the links that I will be referencing in the slides, so they're live and you can capture them. Links to the Gravity webpage, some of our materials into one of the foundational, like my favorite data justice paper that I'll be talking about when we get to our data principles. So I tried to top load those because once I start talking, it's difficult. I don't think I can see the QA and it's hard to access the chat. So hopefully you'll have those live and can follow them after the presentation or during the presentation if you desire. So I'm going to briefly go over the Gravity Project team, the background or why we're doing what we're doing, and if the prior two presentations didn't make the case for why, I'll try to do a little bit extra effort there. I think Dr. Pinto made a pretty good case. I'll discuss the two different work streams. Again, I lead one, I lead the terminology work stream. I'm describe the methods of language making for social determinants of health. And I'll briefly go into the technical work stream, which is led by my colleague, Bob Dieterle. Again, not my area of expertise, but I do my best. I'll address some key questions I want to leave you all with that we have kind of ferreted out in our work at the Gravity Project, and to describe some accomplishments and success factors, and then describe how to engage. I do want to state, of course, that the payer ecosystem and some of the services ecosystems of our two countries are vastly different. So I do apologize for any US-centric discussion that comes up in the presentation. Much of our terminology work is actually international, so I hope it's relevant for the work you're doing in Canada as well. So the team is as follows. So our program and project management all comes through EMI advisors who are well versed in the data standards and policy world. Evelyn Gallego is our program manager. Carrie Lausberg is our project manager. We have policy assistance from my colleague Mark Savage, who's a policy expert. I lead the clinical informatics work stream, and then my colleague Bob, as I mentioned, leads the technical work stream. This is a complicated org chart, but it just wants to show you kind of the governance system that is infused in the Gravity Project now. So what started out as kind of a conversation between friends, talking with our colleagues at UCSF Siren, has turned into a national, very government embedded initiative. With we have a governance structure with an executive committee. I want to pause and just say, you can see in each of our committees, we have intentional stakeholder representation. And so we have representation from patients and consumers, providers, payers, vendors, community-based organizations, because as we say in Gravity, we might identify problems in clinical settings, but we solve them in communities. And then the federal government. So we have an executive committee, a strategic advisory committee, a technical advisory committee. We have those two work streams, as I mentioned, the terminology and technical work stream. And then we have our collective. So I lead the collective meetings that happen. They're open and free with about 1,800 members now. About 100 to 200 members every Thursday show up, and we'll talk more about that in a second. But across all of these different committees, again, the U.S. government is very, very much embedded in our work, both from a data perspective and from a health policy perspective. So this is just a statement on our project grantors and funders and in-kind support. Many hands make labor light, so we only are as strong as our organization. And then now the background. Again, Dr. Pinto and the prior speaker made a very good case. So I just state very basically what we know is the role of social and environmental risks in health and health outcomes are very well known, right? The why we need to address social determinants of health in order to care for patients and populations, that's clear, whether it be from a food insecurity, housing instability, or transportation perspective. They estimate about 80% of a person's wellness comes out of that mix of social, environmental, and behavioral concerns. So why capture social risk data in a standardized and structured way? So as care for social needs has advanced in clinical settings, there's an increasing demand to expand and standardize the terminology to address social needs. And this is in order to better care for patients with social needs in the populations they live within, to collaborate with clinical and community partners, to study social needs, their effect on health outcomes, and the effects of our interventions to address them. And in the U.S. perspective, again, our U.S. frame is to allocate resources toward social risk within value-based care. So the U.S. Healthcare model is largely fee-for-service. So as we try to change this, addressing and documenting patient social risk is critically important to ensure that we're having the right resources flow to the patients that need them. So the Gravity Project came out of a multi-year initiative to basically define the lay of the land for social risk data in U.S. healthcare settings. So there was an initial meeting in 2017 in DC that called national and international experts in social determinants of health to discuss where we were basically. And the assessment was there's a lot of social risk data out there. We don't know how good it is. Again, this is healthcare terminology when I say data. We don't know if it's the correct terminology. And so we need to basically identify what's out there, assess gaps, and then make sure that we fill those gaps based on the evidence. Out of that gathering, I wrote a paper with our colleagues again at UCSF Siren. It's called the Compendium of Medical and Social Needs. You can find that on the UCSF Siren website and in the links below. We found a lot of code. We found lots of screening questions, lots of procedure questions, lots of diagnoses and assessment data, lots of treatment and intervention data, but it wasn't, again, assessed for how good it was, how well it matched the domain at hand. Another reason why the Gravity Project was born was what we know regarding capturing and exchanging social risk data. So when we talk about social data, I'm not just talking about what's in my own system. We're really talking about the complexities of documenting and sharing information, not just with clinical settings, but community-based organizations as well. So there was a paper just recently in August on the challenges in social determinant of health data capture and exchange. And these are challenges of consent, like how to manage consent as data is exchanged, challenges of standardization of social determinants of health data collection and storage, and Dr. Pinto talked at great length regarding standardizing data collection through standardized questions and answers, data sharing, and this is part of what I just discussed, comfort with digital solutions, because if we're going to be talking about sharing information or what we call interoperability, we have to assess various levels of readiness to do the work. Concerns both from a patient perspective and a community-based organization perspective and a policy perspective on sharing that data, really on social care sector capacity and capability. So as the US particularly has moved to address social risks in clinical settings, there is an increased burden on the community-based organizations that have been doing this for a long time. And are we developing the infrastructure to support that work in the community, driven by the community, who will help us solve the problem? That's an ongoing question in the US space, at least. And then there is a pushback on possibly the unnecessary medicalization of social determinants of health, like what is clinically relevant, what is community-based, and how do we make sure that we really are centering the patients and communities in our work, as Dr. Pinto spoke to. So out of all this, the Gravity Project was born. So in May 2019, the Gravity Project was launched as a multi-stakeholder public collaborative. And the goal is to develop, test, and validate and standardized SDOH data for use in patient care, care coordination between health and human service sectors, for population health management, for public health, value-based payment, and clinical research. And this is again a nod to our colleagues at UCF Siren, who were the anchor organization for that initial work starting in 2018, working with our colleagues at EMI, who are now the program and project management team. And it was all started through a grant from the Robert Wood Johnson Foundation. This first link is part of what's in the chat if you want to follow it to the Confluence site. So the goal, again, rephrased, is to develop consensus-driven data standards to support the use and exchange of social determinants of health data within the healthcare sector and between the healthcare sector and other sectors. You can see our roadmap of the domains we're covering is fairly robust. I'll go through some of the domains we've covered so far and our approach and what we've learned in the timeline over the next few slides. So the use cases that ground this work, again, from a terminology and kind of grounding perspective, are as follows. We aim to enable the documentation of social determinants of health data in conjunction with the patient encounter. And this is standardized terminology from our healthcare terminology standards organizations, such as LOINC from Registry, SNOMED CT from SNOMED International, and ICD from the World Health Organization. The next use case is to document and track that social determinants of health related interventions to completion. So if Dr. Pinto in his screening and is identifying a need for a patient, referring to an outside organization to address that need, how do we enable the capacity to get that information back to the clinical setting so they can know the need was met? And then the last one is to gather and aggregate SDOH data for uses beyond the point of care. And again, this is population health management, quality reporting. We're working with our partners to develop social determinants of health specific quality measures, and risk adjustment and risk stratification. So Gravity has convened over 1,800 participants from across the health and human services ecosystem. This includes clinical provider groups, community-based organizations, standard development organizations, federal and state governments, payers and technology vendors. We have a public call that's open to one and all from 4 to 5:30 EST every other Thursday. And you can see the membership of those of the collective at one of the links that I posted in the chat. Again, these are our work streams. So the terminology and technical work stream are intertwined. We work side by side. So as I'm leading the development of the terminology to address social determinants of health, Bob is mirrored and marrying that work in order to enable the technical specifications within an HL7 FHIR, which is a standard developments organization, to share the terminology we're creating through web-based methods that allow for the meaning of what I'm creating and we're creating in the terminology side to be maintained. And we'll talk more about that in a second. But so what we do on the terminology side is we collectively work to develop data sets for each individual domain that represent what needs to be said, and then we analyze those gaps, and then we submit new codes to our standards organizations who are at the table. So almost all of our public meetings, we have representatives from LOINC and from SNOMED CT and from the CDC and ICD-10-CM at the meeting, just watching and making sure we're all speaking the same language. And then eventually we'll publish value sets for these individual domains in our Value Set Authority Center at the National Library of Medicine for the US. I do want to state again, much of the terminology we're building, and you'll see this in the slides ahead, from a programmatic standpoint or an intervention standpoint is US based just because of US programs, but the goals, diagnosis, and even the screening questions and answers are largely international. So this is our roadmap. I know it looks probably a little overwhelming. So where we are right now is represented by the green line. So over the course of the last few years, we've gone domain by domain to address food insecurity, housing instability, homelessness, inadequate housing, financial insecurity, less than a high school education, being a veteran, being unemployed, transportation insecurity, and we just completed material hardship and just completed stress, right? These are all domains as identified by a seminal paper from the US National Academy of Science and Medicine on what domains to focus on first. We will wrap up social isolation, intimate partner violence, and elder abuse from a screening questions and answers and diagnoses perspective by the end of June. Again, all along with this work, my colleague Bob Dieterle is leading the technical work in conjunction, so building that interoperable data standard to enable the exchange of the information. We'll again talk more about that in a bit. So I'm going to speak briefly regarding the terminology work stream, and then again regarding the technical work stream, then have some thoughts and considerations and go from there. So terminology, that's what I lead. So I'm first going to speak to what exactly we mean when we say community data set identification, because this is the heart of what we do. So the community data set identification is a collaborative consensus process that leverages peer-reviewed literature, subject matter expertise, terminology and informatics insight, and the brainstorming of the collective to develop a comprehensive data set for each domain of reference. There's these phases in our work. So we identify and brainstorm together. We collectively sit back and review the data set for completeness. And then we have a consensus vote on that data set. And then we analyze that data set for gaps, as I referenced on the model. And then we build terminology with our data standards organizations to address every gap. And then we test, evaluate, feedback, and the loop goes on. I really think it's important to call to light the evidentiary grounding of that identification process really clearly. So we have a team at Gravity. We have a clinical informatics and process insight. That's largely me, the clinical informatics, and we have a few other clinical informatics reps in the group. We have terminology and taxonomy leadership. We have, for each domain of reference, we gather subject matter experts who are, hold deep evidentiary grounding and content expertise in the domain of reference. And this is both from a measurement perspectives like psychometrics and measurement and screening tools and questions and answers, and health risks and intervention. And then we also have the community. So between all of these, we're always balancing clinical and process insight, terminology and taxonomy insight, the literature and evidence of the domain at hand. We also bring in public health literature to represent risk related to health outcomes, because if we're making decisions regarding terminology, we really want to make sure the health risks and the health concerns that that drive the elevation of that social risk are front of mind. And then the community is a really good practical fit. So the community is just this broad collective. They help us analyze whether things are necessary and not. Again, we imagine this a many year project. So we really want to start with what's necessary and be fairly practical, so the community gives good pushback about that. All the data is sorted across 4 different activities into this master set, as I talked about. So this is a visual that represents that sorting. So we gather and collate standardized and validated screening questions and answers into one part of the data set, basing our approach on some of the US methodology through our census, through our USDA food security module, which is the sister to the Canadian module, through American housing assessment, and through standardized disseminated national screening questions and answer sets. And then those are married and matched to the terminology they're associated with, which is LOINC or registry. We do the same for diagnoses. So we consider the domain of reference, what needs to be said about that domain, what terminology exists for that domain, and then we build collectively into SNOMED CT or ICD-10 which is the US extension of ICD-10. We then do goals, and when we're talking about goal setting, we identify both patient-centered goals from the patient perspective, their own goals for care regarding that social risk. And this is working with our patient advocates and patient representatives, and also goals insofar as quality measures, insofar as treatment goals, I mean, so what a provider goal of care might be. And then lastly, we consider interventions, and I'll talk more about that in a few minutes, but this is all then built into SNOMED CT. What am I doing to address the risk that's identified? Again, so you have a food insecurity identification, what programs, professions, or people am I connecting that patient to once the risk is identified? So we identify all of these concepts that we need to say. We reflect again on what codes are available to represent these critical concepts that we've identified, and then what codes are missing. We do want to just to restate again, so we don't just take this, what is there, what does the evidence say perspective. We also think about our stakeholder perspectives on data. So we're taking on and off the lens from a terminology or clinical perspective, but we're also thinking about perspectives of what kinds of data does the provider need to take care of their patients, a hospital need to study the effects of provider interventions, a community-based organization need to address the needs of their clients or make the case for reimbursement through revenue sharing, a state need to plan for population health, and what principles do we need to consider to keep patients at the center always. Every time, this is regarding interventions, so we are a terminology organization, so everything has methods. So whenever we identify programs, professions, or people that need to be considered to address a given problem, we wrap all of those programs and professions and people with standard agreed upon interventions that have a common definition. So assistance, coordination, counseling, education, evaluation of eligibility, which is critical for US programs like, food stamps or, Section 8 housing waivers, evaluation assessment, provision, which is when you're directly giving something to somebody, and referral. So all of these terms, you'll see them kind of marry in syntax in a few minutes. And then over the course of time, as I mentioned, once we've identified that data set we need to say, the US works with, the Gravity team works with US and international terminology standards organizations to build all those concepts into code. So all screening questions and answers that we've identified as critical get built into LOINC by working with registry. All diagnoses that we identify as critical, we go 2 different directions, both with ICD-10 through the CDC, and through SNOMED CT via the National Library of Medicine. Again, right now, even though we submit to the US, we're doing a lot of our build with diagnoses across international SNOMED CT because of the dearth of social risk concepts in SNOMED CT as it stands. When appropriate in US use, we build across billable terminologies such as CPT and HCPCS, which are US specific. This is an example of what this might look like based on what Gravity has done so far. So food insecurity was our first domain that we covered. It's actually how I came into the project. I came in as a food insecurity expert, and I am an accidental informaticist. So this is what happens, I guess. So if you were thinking about how this might play out within real terminology regarding a real problem, the way this would play out is as follows. So within screening and assessment, All of the US core tools for assessing food insecurity as endorsed by the United States Department of Agriculture are now built into LOINC. That critical 2-item questionnaire, or the hunger vital sign, is built into LOINC as well. I believe that might be the tool that Dr. Pinto is referencing. And so you can ask patients questions, get standard answers, and you're able to share that information and maintain the meaning, because we know exactly what's said because it's retained in the data. And then with diagnoses, we already had, that was one of our first initiatives, we have a food insecurity finding code within SNOMED CT. And you'll see very shortly in the US, we have a very robust expansion of ICD-10 that's coming to address social risks very shortly. Within goal setting, you have the meta goal, which would be food security. And then we broke down sub goals for the subtype experiences of food insecurity, such as number of meals and snacks daily, or quality meals and snacks daily. Again, this is aligned with the domain, because sometimes you need mini goals that are actionable. You might not help the person be fully food insecure because of the heft of their daily experience and the chronicity of the condition, but you can address small things and have small wins. Within interventions, here's some other examples. So you can see all the US programs to address food insecurity are built in, which we call, there's a program called the Child and Adult Food Program. You can see very universal concept is a provision of food voucher. And you can see that we've built a concept for a really critical role within US healthcare to address social determinants of health, and this is the community health worker. I'm unaware if you have a correlate in Canada in healthcare practice, but what we often do in the US is elevate lay people as connectors. So as we identify situations in clinical settings and solve them in the communities, these lay people or connectors are the navigators that help patients get from the identification of the need in the clinical setting to the need being met in the community, and they remain a constant presence for the patient as they go through that process. So we build, again, terminology to represent those professions as well. This is an example, very small, and I did put it in the chat, the ICD-10 CM submission of the robust expansion of terminology. Again, this is only in the US right now, because it is in our US extension, but pending build, we'll be able to specifically document food insecurity, transportation insecurity, housing instability, which is unstably housed but not homeless, which we know is critically important from the healthcare literature, and also financial insecurity and material hardships. So this is all expansion that's going to come over the next year or so within US ICD-10. We are working, I do want to promise everyone, with the World Health Organization to try to get as many of these concepts as possible into ICD-10 11. We know that's a few years out, but we've already learned so much from our work. We're trying to make sure we advocate for the next version of ICD-10 to be able to represent these concerns. Again, this week, Dr. Pinto was talking about COVID, so we want to specifically highlight some of the terminology that's coming, that we've learned to be relevant regarding the COVID use case. So within our diagnostic terminology, we're asking for a differentiation between sheltered homelessness and unsheltered homelessness. This is in order to be representing transitions of care and considerations for non-congregate housing within COVID positive individuals. We do have a concept coming within SNOMED regarding substandard housing due to overcrowding. And again, this is to correctly enable supported housing to enable isolation in the presence of a COVID positive individual. We also have concepts coming for all of the core elements of inadequate housing, whether they be lack of adequate plumbing or presence of contaminants in the household or lack of safety or mold. Those will all be blooming over the course of the next year in international SNOMED as well. And again, specifically interventions you think about within the COVID use case, we have platforms in the US that help make vendors that help make the connection between clinical and community settings. So we enable referrals to that through our terminology. We have specific kind of anti-poverty agencies through US policies, so we're enabling the referral to those. Again, there's that community health worker, which is the critical connector. And then there's a representation of entry into our system that manages applications for housing within the presence of homelessness. So again, all of the interventions are not international. Those would just be kind of plug and play with the Canadian approaches and Canadian programs, unless it's a role, like we can imagine the community health worker being something that might be applicable across international settings. Oh, this last one, it's not bolded, but it's actually really important. We also asked for a specific concept for what is called medical respite. So this is when an individual is homeless and they need to, and they can get admitted to a hospital setting because they have a critical, because they, the homelessness plus the illness warrant the admission that otherwise might not warrant admission status. So this is, it's called medical respite. And it's a really critical finding and intervention within U.S. Within U.S. homelessness health risks and the research that we have there. This is just the confluence. This is how to access everything that I just mentioned to you. The confluence is massive. So it's like 2 years of labor representing work streams across terminology, technology, policy. If my contact information, I think, is at the end, and you can always write me an email. Marcy's aware I try to be fairly available. I just might not write back immediately because I do work in clinic. But this is where you can find all of our work, and this is where the community finds the work that we're doing regarding each of our individual domains. You can see each domain has a button. Each button takes you to that data set that we're developing, and you can learn about where we are in that process, whether we have completed the data set and it's in build, whether we've completed it and it's been released. You can see every single data point regarding the data development in the confluence. Just trying to find my button back, here we go. I did want to spend a moment, again, this references something Dr. Pinto was talking about as well, and I highlighted a paper in the chat. There's a lot of work regarding data justice. The Gravity Project identifies itself as a social justice driven organization. So as we consider addressing what Lynette Taylor, who's the author of the study, of the paper that I put in the chat, which Lynette Taylor calls the injustice of invisibility. So as Gravity builds terminology to define social risks, the risk of being hidden or the injustice of being hidden is addressed. But as we address the injustice of being hidden, you suddenly have the risks of being in the ecosystem. There's so much amazing and really powerful research regarding data justice in ecosystem, whether it be Dr. Ruha Benjamin, Meredith Broussard, Kathy O'Neill. So all of this information is part of what we do at Gravity. And out of that, we created data principles. So the Gravity Project, data use principles for equitable health and social care. And these are the core principles. And again, I did the link in the chat. So all the terminology work we just described, addressing that risk of being invisible and being hidden, elevating these concerns into the healthcare ecosystem. These are the things that we need to keep in mind, right? That the goal is to improve personal health outcomes. The goal is to improve population health equity. We always need to make sure we're ensuring personal control. We have to make sure that we're designing appropriate solutions. And these are all unpacked in the link. We have to make sure that we're ensuring accountability, and in every single thing that we do, we have to aim to prevent, reduce, and remediate harm. So as we do all of our work in Gravity, these are the principles that ground us. And again, they're based on some of the literature regarding data justice and bias and everything from what's not being mentioned, such as the Indigenous or COVID data project in the US, to what happens when you do have data with bias and algorithms and all the concerns that happen therewith. So there's a link in the chat, as I mentioned. I'm going to briefly go into the technical work stream, and then we're going to open it up into Q&A. Again, technical work stream is not my domain, so I'll do my best to pinch hit for Bob. So the Gravity Project is an HL7 FHIR accelerator project. So FHIR, Fast Healthcare Interoperability Resources, is an interoperability standards organization that works to address concerns of providers, health directories, public health research, social determinants of health, that's us, clinical decision support and payers. So you can imagine what happens is as we identify all of our data sets for each of those domains, and we build them into code, and we create these value sets that we are able to reference within our Value Set Authority Center. Those value sets become the anchor of the terminology for exchange of information across settings using HL7 FHIR. So our HL7 implementation guide, again, it's right here in reference, and I don't think I put it in the chat, but I can do so. It's called the Social Determinants of Health Clinical Care FHIR Implementation Guide. It again supports the same activities that the terminology work group is doing, except for a couple more. So again, being able to share information on assessments, on health concerns and problems, on goals, on interventions, including referral tracking, on consent management, and on aggregation. So that if those of you, any of you are familiar with FHIR, the ballot was completed in January 2021, and now we're working on revisions. The use cases for the FHIR implementation guide, again, this is about data exchange. So some of them are the same as terminology and some are not. So it's again about SDOH data in conjunction with patient encounters. They add documenting social determinants of health related goals, so the patient goals of care can be exchanged with patient consent across different settings. Again, it's the same established and related interventions to completion. So documenting and tracking referrals, making sure the interventions are completed. That's part of the technology use case as well. They add documenting and measuring outcomes. This is both to enable quality measures and to make sure that when you identify a goal associated with a problem, you're actually achieving the outcome you intend to achieve. There's that same aggregation of information use case as well. This is all within the IG. And again, managing patient consent. So across every single phase, again, from a social justice perspective, always trying to figure out what information needs to be exchanged, how is patient consent established, every single movement of information across different settings. These next wireframes are really quite complex. It's just to say these are all the pathways of information exchange the implementation guide is attempting to represent. So whether the information originates from a provider in an EHR, from a payer, or from a public health agency, who is the person who is naming the information, whether it be the patient or a legal representative or a caregiver, how are community-based organizations participating in that information, and what kind of technology do we need in order to enable the exchange. I'm going to go more into the technology bit in a second. This is just another version as well. You can see these are the pathways of information exchange that they imagine. And some of this right now is based on program type and what we're learning in the implementation guide and considering data exchange. So we're likely going to move away from considering organization type to really just basing on what can people do, like what functions can a person perform? Because often in the social services sector, if I can't solve your problem in the food bank, I'm going to bump you over to the church down the way, and we're going to keep on trying to drill on the problem to make sure that it's addressed. And it's not as linear as this kind of organization only can do this thing. So this is a work in progress. Now on to some key questions, and then some success stories, and then questions from you. So key questions for us. I really just want to make sure that everything that I presented, which you can find on the Confluence, it probably was fairly overwhelming because what we do is kind of complex. There's some really important terminology and technical considerations that weave through everything that we do. One of the things that we consider is how fit it is to adapt public health social risk tools and definitions to clinical use cases. So as we work on our domains, we're often adapting definitions that were common in public health settings to meet clinical use cases. The example of that is our food insecurity definition that we had to refine really to be person-centered and represent the concerns of the individual. And we did that in collaboration with experts at the World Health Organization and US and the United States Department of Agriculture and food insecurity researchers across the world, just to make sure we got it right. As I mentioned this already, so we consider what happens when you address the injustice of invisibility and need to anticipate address the risk of becoming visible. So this regards like how do we, for that preventing, reducing, and remediating harm concern. Again, on consent, we have very, very vocal and engaged patient advocates throughout our organization that make sure that we're going to get this right. We also are always considering how to represent goals. These include patient goals, provider goals, and patient-reported outcomes. We're always asking ourselves what's necessary. So the minimum viable product, like what do I need to make, what do I need to exchange in order to get my patient taken care of well. And again, this is actually part of that lens of preventing, reducing, and remediating harm. So if I make the package as trim as it needs to be, there's not excessive information going into the ecosystem, the privacy of my patient is as intact as it can be. One of the things we've also identified is a need to establish what we call a taxonomy of programs. So although we have I have a number as an individual, we have a taxonomy for medications, really these critical national program types that we use to address social risks. Without that, we have really clunky what's called syntax, right? I can't just wrap a program with an activity and send it off. Everything has to be basically a sentence, like referral for food stamps or referral to food bank. So we're working on developing that syntax for each of those different program types as well. We also work on trying to consider how the language I use in healthcare settings mirrors the language that's already happening in human services worlds. Like the language that's happening, we're addressing food insecurity in the Canadian government. The language is happening addressing housing, right? So each of us have developed our own terminologies over the course of time. Healthcare is actually fairly late to the game. So we are always anticipating how to make sure we're in keeping and in kind with what's been present in the social ecosystem before us. And the last thing, and then there's the cascading referral patterns, like if someone's getting bounced around to different agencies in order to get their need met, like how does the referral come back? And then lastly, this is from a social justice perspective as well, we're very careful to anticipate the labor that we're placing on community-based organizations. So we acknowledge, and that was named in an early slide, there's a technology gap. Many of these organizations that are working in communities don't have the robust infrastructure of the healthcare system. So we're considering how to bridge technology gaps and how to support community-based organizations in the labor of doing so. And then this is a slide on how you can incorporate data standards into your work. This is again the work of the HL7 Fire Implementation Guide. So standardized social risk screening, as Dr. Pinto was talking about, adopting standards of data exchange, and then we always want to make sure that we're engaging patients and caregivers in platform design, and then this is just a work in progress, so shared testing infrastructure. So as you do this kind of concurrent social and healthcare setting, initial steps of developing agreement on what we're saying, the idea is to make sure that that you're also agreeing on how to share that information through trust frameworks and making sure that you have this, you're collaboratively working on solving the infrastructure hurdles that come along the way. I think I'm going to stop there so we have time for questions, but this is just from a very US perspective, our final slide. So what the Gravity Project has borne through its work is policy changes through our federal partnerships, which again are very US specific. There's payment and policy, and there's payment changes that are happening through value-based healthcare initiatives. We work directly with programs and other standards organizations. We participate in the development of quality measures across all social risks. So we just completed a TEP on food insecurity, incoming TEPs on transportation insecurity. A TEP is a technical advisory panel or technical expert panel. We're doing panels as well on housing and transportation, again, to ensure that common terminology we're developing is part of those quality measures. And then we have all kinds of federal grants that partner with our work to make sure that there's the funds that are needed in communities to get this work done is present. How to engage? This is us. And I think that that's it, and we can have questions now. I'm sorry, that was quite a fast and full presentation, Marcy.
That's okay, that's great, because I know it's been like 2 years of work. So yeah, it's been amazing. So that's actually my first question is, as you know, we're trying to start something similar in Canada. And so I guess, are there any key, yeah, I guess what I've been debating is, do we start with the principles, or do we actually take one domain that you've started on and look at it from a Canadian perspective? Those are just some of the 2 ideas that we've been having, Dr. Adeline Conklin and myself. But what I guess is, what are some key lessons you learned, and where would you start if you don't, we don't even have funds yet, right? So we're trying to figure out how to get this going. So if you have any advice around that.
Oh yeah, we didn't have funds for a year either.
Okay.
Not to bust the bubble, but I was unpaid for the first year. So yeah, but I was able to say it was my doctoral work. That was the buy-in. So I think the thing is that there's a lot that gravity is leading on that doesn't have to be replicated. So what we would be able to say is there are some things, hopefully, that that the labor can be shared, like collectively agreeing on what we might need to say regarding social risks, like the terms and diagnoses. Hopefully that work, I mean, based on what we're hearing from the international community, is not work that has to be adjusted too much, right? So there was no term for food insecurity. Hopefully we'll change that, or terms for housing instability, et cetera. Right. So I think what one could imagine doing is assessing what's already ready for go live in the Canadian environment, and then what's specific. And so what we are learning is very national based and setting based. Again, are those programs and interventions. The interventions landscape is very unique. Like, I mean, what even just the term that's used in a Canadian setting for the same type of program will be different. And I think there's just going to be considerations regarding exchange that are much less cumbersome. There's not quite as many players in the Canadian ecosystem as there are in the US ecosystem. I mean, the US healthcare system is just a cacophony of things, right? Yeah. So they're hopefully, what you can imagine doing is analyzing what's happening in the US work, and then just assessing what has to be adapted and changed in the work for Canada, but knowing specifically that most of the interventions terminology would have to be recreated in order to be fit for Canadian use.
All right, great, thanks. There's a question coming up about, can you speak about your planned work on the smartphone apps?
Yes, I know I brushed. Okay, so when we talk about, sorry, there was a lot to say. So I'm going to admit I have questions regarding the smartphone app, but this is the problem. So when you're trying to share information across settings that have vast technological resources into settings that do not, right? So, and ensuring that community-based organizations have the support that they need. One of the methods that we're developing in order to, again, enable that, specifically the referral loop, like how do I ensure that the need I identified has been met, is to use APIs and web-based and handheld apps you can have on your phone, right? So the community-based organization would have access to the app, the patient would have access to the app. And so as the patient is able to navigate to the community-based setting in order to get their needs met, they're able to have the information entered into this, again, this API or this app, and it goes right back through FHIR back to the healthcare setting, and then that referral loop is closed. So it's really like one of the only means we can identify right now in the absence of a national social data infrastructure to allow for information exchange into settings that have vast, like, inequities and different levels of capacity of information exchanging. I didn't even talk about pilots, but as we're doing our work in pilots and in testing some of this, there's 3 strata of pilots we imagine. Like, 1, first, can we agree on what we're saying, right? 2 is, can we anticipate using standards and how standards of data exchange through any method? And the last one is testing the FHIR implementation guide.
The kind, kind of ties into one of the questions that came up was, how do you conduct a risk assessment of a new standard on the community from which the data is being collected? So are there ways that you actually, yeah, I guess engaging with the community?
So I guess there's so many different kinds of risk.
Yeah.
So I guess I want to understand what kind of risk the questioner has in mind, because there's a very specific answer for every different kind of risk. Because is it the risk of collecting the information? Is it the risk of the social domain itself? Is it the risk of the labor, as I was discussing, for the community-based organization? So if someone can help me understand what kind of risk, I will have a better answer.
Yes, I guess, yeah, the risk of the use of the information once it's collected.
Yeah, so right now, actually, we've just done our best to cross-check with all of the experts that we can, and So one of our data principles in that last one, really preventing, reducing, and remediating harm, is we actually document what could be the potential risks for the different domains that we are working on. Like, for instance, when we were doing the unemployment domain, part of what we do is, in our anticipating risks perspective, is documenting the risk of having this in the exchange with given migrant laborers and some of the rule changes that were going on with U.S. citizenship and Medicaid, our federal low-income healthcare qualifications, right? So, for instance, like, if you do not have a job, you might not get citizenship, and you might not get the U.S. healthcare because the U.S., with our past administration, had a rule that said that you were not worthy. Right. So part of what we do, and this is working with both our subject matter experts and our patient reps and our lived experience reps that we use as well, is really cross-check as much as we can. What are the risks that we could possibly imagine regarding this information? And this would include risks of bias and discrimination and harm.
That's great. Going to jump to, there's a question that came up around the ballot process. So I know that you have a consensus ballot through HL7. Do you have something similar with the different terminology such as latency and SNOMED?
We do, yeah. Oh, sorry.
Oh, you do? No, go ahead. Yep. No. I'm trying to read it. Yeah.
So all of our work is consensus based. All of our work is public, right? So the HL7 process is very, very formalized, but within the terminology development work as well, all that kind of the icon line that I represented. So we collectively, as a group, publicly, everyone can submit concepts for consideration. We do that brainstorming bit. We collectively, as a group, do what's called an end-to-end review, which is any person in the collective, any person coming on a call can write an email saying a couple different comments on the set as it's in development, which is something's missing, something's wrong, it needs to be changed, or something should just be removed, right? Because it's wrong, or it's too risky, or right. So that whole process is called end-to-end review. And then we have a consensus voting process, which uses really the same HL7 standards votes. And again, so you can say all good, yes, yes with comment, which requires resolution. We just completed our vote for our stress domain, or you can formally say no with an objection. An objection requires a path to remediate your concern, though. So you can't just say no. You have to say no, do this, right?
Yeah, yeah, it's great. Yeah, I was actually on the last call, and so I admired your ability to see the chat and actually present at the same time. So that's quite a skill.
I know, it's like I joke, it's like a Texas cattle auction.
Yeah, it's amazing. So speaking of stress, Annalyn actually has worked in this around stress for her research as well. So her question is this psychological stress or physiological stress? And what was the rationale for conceptualizing it as a social determinant?
Yeah, so this is a very apropos question. So we actually operate now in a contract through Center for Medicaid and Medicare Services. So we're bound to complete the domains as they're represented in this contract. This is about to end and will be a little bit more freeform for a bit. So stress was on the project plan as identified again from that National Academies of Science paper on capturing social and psychological domains in electronic health records. I can actually try to chat that paper into, it's a white paper printed by the National Academy. And so that's why it made it on the timeline. As it is, of course, once you start talking to subject matter experts, all of the sticky wickets of saying that you're going to do something come to bear. So part of what we do when we're identifying a domain is create really logical and what we call like psychometric or measurement guardrails, right? So yes, it is psychological stress, excluding some pretty principal concerns. So if you are a researcher or an expert in stress, we based all of our subject matter experts were the folks within the stress measurement network out of UCSF Siren. So really using their framework for dividing different kinds of stress into different types, basing the psychological stress approach on the perceived stress scale, which is the gold standard screen, making very careful decisions to what we call PARC, right? Right now, we very intentionally decided we did not have the right subject matter experts to address minority stress. And so we took minority stress as a package and said, it's on the timeline over here, because we needed to make sure we had the right group of subject matter experts to do that well. So it's on the timeline, it's on our project plan because of the paper, because of our contract. Right, it's defined as it is because of the measurement tools and because the risk associated with specifically that type of stress. And there's things that are not in it because of needing to make sure we have the right team.
Yeah, I think that actually the last meeting I attended, it was really clear that like how you keep moving it forward and to separate these things out instead of, because I can see it would be quite easy to get kind of bogged down in a certain area and the scope really getting too large, right? So
yeah, and we do try to anticipate connections from screening questions and answers to diagnoses, right? So if we're basing our screening question and answer approach and our measurement approach on the perceived stress scale, there's specific answers and outcomes you can imagine just from that tool. Other concepts, other diagnoses might require more refinement, but there are things I can say, right? So that again becomes the kind of like praxis guideline and praxis guardrails. This is what I can say based on these questions.
Yeah, great. Just seeing if there's any other questions, if there's anything. I think that is good.
Wow.
So I do encourage people to go to the Gravity site because it's a bit intimidating, but it's amazing how much is on there. And yeah, I guess I've been thinking about how can we actually use what's there and not duplicate efforts here because make it pull from those resources. So thank you. It's been amazing work. Just wanted to
and thank you for having me. It's really such an honor. And although the website might be intimidating, I hope I'm not.
No,
right?
definitely
not.
not.
I believe Marcy has my contact information and you can always reach out. It's hard to represent all of the work that we do. It's pretty overwhelming. So just let us know if we can help. And we're really, really grateful for our Canadian colleagues. And thank you for having me.
All right, great. And I wanted to extend my thanks to our two earlier presenters, so Julie Stratton and Andrew Pinto again, and Mena for being behind the scenes and organizing this day, and also CIHI and Infoway for promoting it, and UVic as well. So thank you, everyone. The videos will be on the UVic site and the Infoway site. And we'll send out a follow-up so that you can figure out where the link is. So thank you.